celebration of February is Heart Month, and we're calling it Healthy Heart Month. So Olivia and Dr. Dan have been working on their presentation, and it'll be educational and fun, and I hope you all enjoy it. So without further ado, here you go, guys.
I want to introduce our health coach, Olivia. She did most of the work on this, so she gets to warm you up, and then I'll take over. She's going to start with the normal anatomy of the heart and where the blood goes and circulation in general, and then I'll take up some of the disease topics, and then she'll wrap it up with what we can do about keeping our hearts healthy. So take it away, Olivia.
Janelle.
Hi, Jackie.
Okay, do you want to take up the lights? Okay, so first thing we're going to start with, this is what we're going to cover. So anatomy, physiology, the heart diseases, and heart prevention. And then, so the cardiovascular system, what it's comprised of is the heart, the blood vessels, which are the arteries, the capillaries, and the veins. So this is a good picture right here. And what it looks at right here, center is the heart. And so we have the blood in the lungs where you're breathing in, taking in the oxygen into your body, getting rid of the CO2. And also the heart pumping, taking the blood to the body. So this is your upper body, this would be your lower body. And the capillaries down here where the, not the conversion, the transfer between CO2 and oxygen within your body. And then the deoxygenated blood going back up to the heart and then getting rid of it, or re-oxygenizing the blood. All right, and then the heart anatomy. So here we have the four chambers of the heart. So we have the right atrium where the deoxygenated blood comes into the heart. And this is, the atriums are the fillers, and then the ventricles, which are the bigger parts down here, are the pumpers. So here's where we collect the deoxygenated blood, and then you have your valves here, and then it comes down into the ventricle, the right ventricle. Then it's pushed to the lungs, where then the blood gets oxygenated, and then it comes back in to the left atrium, where it collects the oxygenated, and then is pushed back out from the left ventricle to the aorta and out to the heart, to the body. So then we have our valves right here, where when the blood comes in, and when the ventricle here pushes it out, you have the valve that closes, so only the blood can be pushed out through that artery. Any questions on the anatomy? No? Okay. All right, and then we have the front of the heart, so we're looking at the coronary arteries here. So you have your veins and then also your arteries. So when you hear coronary artery disease, this is what we're talking about. This just kind of covers the arteries, but you also have your capillaries that cover this entire area. So your blood just isn't going to this certain part of the heart muscle, but there's more capillaries around. And then you have your electrical system. So you have your SA node, which creates a action potential, and this is how your heart pumps naturally. So you have your SA node that creates the action potential, and then it comes down to this AB node, which then pushes the action potential down the bundle branches, and then the bundle branches come out into the what are they called again? Purkinje fibers. And then this is what creates that contraction in the ventricles. Whoops! Yeah. So then you can, so when you hear of also like a bundle branch block, sometimes you'll hear of a bundle branch block within the conduction system of the heart. The action potential comes down and then it actually slows down if there's a block, and then the contraction is slower than the other contraction on one side of the ventricle, or one ventricle. And then when you have a heart block, there's a block in the electrical system, and the action potential within the SA node and the AB node is slower, and sometimes it gets so slow that it doesn't, where it doesn't exist? It doesn't almost exist. And then so the contraction's really slow. And that's when either a pacemaker comes into play, because this is your natural pacemaker. So when you have a blockage, then sometimes they have to put that pacemaker in. Okay?
What does SA and AB stand for?
The
Sinoatrial,
sinoatrial.
atrial, and then the atrial ventricular. So the sinus is the little cavity where the node sits. That's your natural pacemaker. And then the AB node gathers that pulse of energy, that electrical current actually, which we can see on your electrocardiogram, and then distributes it down the, those are actually like wires, they're just little conduction systems, those yellow marks there. And so it's definitely the electrical part of the heart that Olivia's describing right now. And just like any other electrical system, it can short circuit or it can lose its generating capacity, and that's where the artificial pacemaker comes in. So it's an amazing part of the technology that's developed that we take for granted. I know we all either have pacemakers or know somebody who does. And we've actually diagnosed it right here in this office, where someone would come in for just a regular checkup and say something like, well, I was having trouble getting up my steep driveway to get my newspaper this morning. I got a little short of breath, and checked his pulse, and it's going about 20. And we did an electrocardiogram, and he's got a complete heart block, and it's just beating spontaneously by electrical activity coming from the ventricle itself. That's a safeguard. If you were to look at a worm heart or some other less complex organism, they just generate their pacemaker from the muscle of the heart itself. So we're so sophisticated with our higher evolution that we've got this electrical system, but we still have the backup. We still have that backup, and that's what this man had. He had pulses being generated from the muscle itself. When he walked in here, we had to call an ambulance. They looked, you've got to get to the hospital right away. He got a pacemaker that night and was home the next day. He would have just come in for his usual checkup. So those kind of things are what give doctors gray hair, but it's really satisfying to be able to see something like that and do something about it and see the system work.
And this is also how the EKG is created too, with that electrical stimulation within the heart. So that's why we use the electrodes during your exercise test and when you're doing 1-3 rest, things like that. Okay, and Dr. Morris is going to take over.
Like I haven't already. I want to keep this informal. So, hey, come on in, Glenn.
Come on in, have a seat.
Yeah.
There you go. Sorry
Um,
about that.
So, Olivia talked mostly about the heart in health. This is Heart Health
Are you happy to
Month.
stand?
So we
Or would you
want
like to sit
to
over here?
contrast heart health with heart disease. That's what doctors traditionally have done so much of, is focusing on disease. With our practice, we're trying to turn that back to where we're spending more time talking about prevention. But we need to know what we're preventing, and so that's where we come up with all the things that can go wrong with your heart. And I'd like to go through just a few of these conditions like the valves. Regurgitation is where the valve doesn't close properly, so the blood regurgitates back into the chamber from which it came, and then that puts a strain on that chamber. If that happens to be on the right side of the heart, your legs can swell. If it's on the left side of the heart, you can get blood pooling in your lungs and develop heart failure. So that's where we always worry about, well, are you having shortness of breath? Are you having leg swelling when we're talking about your heart? Here's a picture of the valves themselves. These are normal appearing valves: the aortic valve, pulmonic valve, tricuspid, mitral. There's 4 of them. Your heart is actually 2 pumps. The right side of the heart is a separate pump from the left, but they pump in tandem to move the blood from your body, from your organs, from your muscles, up into the lungs to give the oxygen to the blood, and then from the lungs through the heart again on the left side, which is where the big pump is, the left ventricle, and then that pushes the blood out into the organs and your tissues and your muscles. And that's why the left side of the heart is so much more important, we say, from the standpoint of you don't want to damage that because it's the big muscle. It's the pump, the main pump for your circulation. So when looking at the valves, you can see that things can go wrong. Here's the diseased valves, stenotic or narrowed valve, just like you can have stenosis in an artery. Stenosis just means narrowing. You can have a valve narrowing, so not enough blood can get through. And the aortic valve is pretty amazing in that all your blood has to pump through there to get to your muscles, your organs, your brain. So when this gets too small, normally it's about 2 square centimeters is all the area there. And so when that loses any of its cross-section, then you start getting symptoms. You feel weak, you feel dizzy, your blood pressure may be on the low side actually, because the blood pressure is generated from the pump moving the blood out through your arteries so that we can hear the pulse in your arm once we deflate the blood pressure cuff to the point where some blood will start swishing through. And that's what we hear when we check your blood pressure, is that pulse of blood generated from the heart muscle pushing the blood out through the aortic valve. So if the aortic valve has a problem, that's one way to pick it up. And likewise, the other valves have similar problems. An interesting thing about your legs, as we age, we tend to have swelling in our legs. It can be from sitting too long, it can be from riding on an airplane, it can be from eating too much salt. Why is that? Why is it that young people just don't have problems with leg swelling and we older folks do? Well, some of it could be we gain weight as we get older, and so that puts pressure on the veins and the blood can't get back to the heart very well. But then also, as these veins age, the little valves in the veins become incompetent, and it's a good term, incompetent, it isn't doing its job. So what will happen is the normal vein where the muscle contracts and moves the blood back up toward the heart. As those muscles contract, it squeezes the blood up back toward the heart. Then when the muscle relaxes, the vein valve catches so the blood does not go back down. In an incompetent valve or a diseased valve, the blood will go both ways. Your muscle contracts, moves the blood up. Your muscle relaxes, it comes back down. So that's one reason why you can have swelling in your legs, which is not particularly a heart problem, but it is a vascular problem. It is in one of the blood vessels of your body. So that has to be distinguished, of course, from retention of fluid from your heart pump not working very well. So what else can go wrong? You've got your cardiomyopathies, which is just determined from the Latin for heart, cardio, and myopathy meaning a muscle disease, myo meaning muscle. So normally your muscle thickness is at a healthy range. As you get high blood pressure or other problems with your valves, you can end up with thickening of the muscle, and then that restricts the filling of the blood in the chambers, and therefore restricts your total circulation, so there'll be back pressure into your lungs and your other organs, causing shortness of breath, leg swelling, weakness. And if you've had a heart attack, you've damaged some of the muscle, and in that situation, the muscle is thinned, there's scar formation, and this causes a dilated cardiomyopathy, which dilated just means enlarged from a sac-like situation rather than enlarged from a muscle thickening situation. So you'll hear these terms bandied about in your echocardiogram reports or read about them, and this is some of the explanation for it. Now, the big one, of course, is atherosclerosis. That's the one we always think about when we hear about a heart attack. And there can be a lot of misconception about what a heart attack is. If your heart stops, that's a cardiac arrest. Now, that can be due to a heart attack or a myocardial infarction, but it's different. The heart attack is, in common medical parlance, is the myocardial infarction, also previously known as coronary thrombosis. And this is the one where the heart center with their big billboard and advertising for doing stenting and heart bypasses, this is where they do their work. And the artery, of course, is the coronary. The coronary arteries that Olivia pointed out are small arteries that go on the surface of the heart itself, and those arteries penetrate into the heart muscle and supply the blood to them. As you could see from the previous slide that Olivia showed, those arteries are pretty small considering the size of the muscle of the heart. So it's a little bit of a design problem there. Your heart muscle is big compared to the arteries that supply it. And that's one thing we concern ourselves with cardiac rehab and prevention. If you've had a heart attack, you want to develop collateral flow, improve the other arteries that are still healthy. And to do that, you need to exercise. Your heart is a muscle, just like every other muscle in your body. It needs to be exercised, but even more so, because it's such a crucial muscle. Now, what happens with the disease process of atherosclerosis? Well, you go from a normal pattern here of a normal lumen size, and then you develop fatty streaks. What are these fatty streaks? Well, they're cholesterol deposits and other inflammatory cells enter the lining of the blood vessel wall. What causes that? Well, we think there are many things that cause that. Inflammation can cause it, high blood pressure can cause it, high cholesterol can cause it, smoking cigarettes can cause it. It became a big topic in medical literature during the Vietnam War because all of our boys that were coming back in coffins, some of them were autopsied and their hearts were looked at, and there were fatty streaks in 21-year-olds. And these were young people who shouldn't have heart disease. So we then started thinking, where is this problem starting? It's starting in our youth. So youth is the time to start working on things like smoking cessation, healthy diet, exercise, and we came up with the President's Fitness Program. I remember when I was in high school, we had to get out there and do the President's Fitness Test to show that we were on the right track to prevent disease as we got older. So after the fatty streaks occur, then you can have actual plaque. And what is a plaque? Well, it's just a thick and fatty streak is what it is. I think most of you have had me do the carotid artery ultrasound here, and we talk about the thickness of the lining of the carotid artery. Now, why the carotid artery? Well, because we can't see your heart very well as far as those coronary arteries, but here's a nice big artery, nicely exposed out here, where we can do an easy test that gives us a window to your circulatory system. So we talk about that thickness, and then we correlate that with your age and the statistics of other members of of our population. And if that thickness is more than 1.3 millimeters, it's defined as a plaque. So it's just a matter of thickness. So you can see there's a continuum here from a normal lining to a somewhat thickened lining to suddenly we've got a plaque. And then what do we have after we get to a plaque? I'll get the hang of this before long. Then we have a stenosis. So plaques keep building up and become circumferential or go all the way around the artery, and then you have a stenosis. Yes, sir. Tom?
Once you reach a certain point of deterioration, can that be reversed at all, or are you just stuck with it at that point in time?
That's a really good question. There's evidence that shows that by lowering your cholesterol, stopping smoking, lowering your blood pressure, reducing inflammation, and treating insulin resistance, which we talk about a lot, that reduces the inflammation and allows you then to reverse this process. It's slow, but that's why we want to do these carotid tests on a yearly basis to see if it's getting better or getting worse. But there is some medical evidence that this can be reversed. Back in this stage in here, you can see how once you've got a circumferential problem, the chances of reversing that are pretty low. And this is way downstream in your blood flow and way downstream with the problem. We want to work on upstream problems, which are milder and easier to deal with. So when you go to the heart doctor and he says you need a stent, it's this stuff here. The interesting thing about it, and something that they don't always tell you, is that most heart attacks occur back here. These plaques that are younger are more prone to do what we call rupture and cause a blood clot. So we're talking here about coronary artery disease, in other words. The plaque builds up, the plaque narrows the coronary arteries, and then your symptoms when you have a stenosis are, okay, you don't have much exercise tolerance, you can get angina, you take a nitro, you stop, you rest, it feels better. That's not a heart attack. That's just lack of blood flow to the heart muscle because of the stenosis. A heart attack is where a plaque ruptures, the platelets then stick to the rupture, and then a clot forms. The platelets are sticky, and that's why we take aspirin to thin our blood a little bit. And the blockage then created by this blood clot is the cause of the lack of blood flow to the heart muscle. The heart muscle then is injured and dies, and then you have the damage done. That's why we make so much of a fuss about being in a hurry. If you have a chest pain and you think it's your heart, we want you to call 911, because if you get to the heart catheterization lab within a few hours, they can open that up, put a stent in, and prevent the heart muscle from being damaged further. In other words, they can abort the heart attack. So this is where that happens. This again shows you the heart muscle itself with the coronary. Just look how tiny these are. And this is really pretty accurate depiction of the size of the heart muscle versus the size of the blood vessels that supply it. And when I was early on in my training, I thought, well, why can't the heart with all that blood in it just give itself some oxygen? Well, it can't, because the lining of the chambers prevent the oxygen from diffusing into the muscle itself. It requires what Olivia was talking about, that capillary bed, where the artery splits into the finer arteries, the arterioles, and then the capillaries, which are only one cell thick. And those little one cell thick capillaries are where diffusion takes place. The oxygen diffuses between the cells. The CO2 comes out of the muscle and goes into the veins then. That's the blue part of her slide. So these are crucial to our health, and you can see how a normal one is just slick as can be, normal, and then as we get the disease, we start to have these plaques forming, and a stent can be placed in them to keep them open. But this is pretty crude when you think about it, you know, putting in a stent, and then one stent leads to another stent, and before you know it, you've got stent upon stent, your entire coronaries are filled up, and they can only go so far down. You can see how the artery itself narrows, as it gets smaller and gives off its branches. A cardiologist cannot put a stent in below a certain level, so that's where medical therapy or lifestyle therapy is key. So we mentioned the difference between a cardiac arrest and a heart attack. The two are related, but they can happen separately. If you have a major stroke, your heart can just stop because of the stroke. And then people will be confused, well, was that a heart attack that caused that? No, there are other reasons for cardiac arrest than a heart attack. A heart attack, by medical parlance, is the actual blood clot causing damage to the heart muscle. Once that damage has been done, you also have a more irritable heart lining, which can then lead to rhythm problems with your heart. That's why we came up with coronary care units, where you can be watched closely to see if you develop rhythm problems, to determine if a heart pacemaker needs to be put in, or a defibrillator. A lot of the newer defibrillators have a defibrillator built with them, so that if you develop one of those bad rhythms, your heart can be shocked automatically to straighten that up. There again, though, that's way down the road. We want to try to prevent that if possible. So this shows the plaque here, the lumen where the blood's flowing. The plaque has ruptured, the platelets are aggregating. Then this shows the actual stenosis that can occur, limiting the flow of blood. And once the clot is in there, nothing can flow beyond that, and an area of the heart muscle then dies. And then this depicts the infarct zone, the scar that forms. And this relates to the rhythm problems also, with the heart being more irritable and more likely to generate abnormal rhythms when it has been starved for oxygen. Now, what is it about this whole situation that causes this problem? And this problem is, we all know somebody who's been to see the doctor, maybe even had a stress test, and then 2 weeks later they have a heart attack. Well, that's because of what I was just saying. The heart attack can occur in a plaque that's rather small. So you could have a coronary angiogram and it could be completely clean, and you could then have a heart attack in one of these smaller plaques that can only be seen by, say, an ultrasound, or don't even show up on the coronary angiogram. And a study was done looking at the standard risk factors that doctors are told to watch for and treat, and that is age. There's not much we can do about age. We're going to get older, so that's not a treatable risk factor. So there's the other risk factors like smoking, blood pressure, cholesterol, and exercise. And those are some of the major risk factors. But when this one study looked at 220 people, there were 110 women less than 65 who had heart attacks. And so the researchers went back and said, okay, what were the risk factors that led to this by the standard National Cholesterol Education Program? These were people who would have been considered low risk by the screening tests. And likewise, the men, of 110 men less than 55, 66% of them would have been considered low risk. And these were people who retrospectively were looked at for having had a heart attack. So what were their risks? They were low risk by standard calculations. So what are we missing here? There's a lot of different risks that aren't really looked at. Of course, one of them is very early disease, like we detect with our carotid artery ultrasound, and also inflammation related to insulin resistance. Now, if you look at diabetics, of course, they're at high risk for heart disease. But a lot of diabetes goes undiagnosed in this country. That's why we do the glucose tolerance test. The standard for checking to see if you have insulin resistance is, well, is your fasting blood sugar greater than 100? A lot of us have normal fasting blood sugar or slightly elevated, but by stress testing our systems, by taking the glucose load, we can see if our blood pressure shoots up towards 200. And then that is a cause for insulin resistance. That's a cause of inflammation in the artery. That's a cause of plaque rupture. That's a cause of heart attacks. So it's all a cascade, and what's part of this epidemic we have in our country of diabetes, obesity, heart disease, cancer for that matter. It goes on and on. This inflammation in our arteries. So how do we detect it? We go looking, and that's one of the cornerstones of our practice here, as well as our sedentary lifestyle. That's a big factor too. We know that if you sit for prolonged periods, your insulin level goes up, your blood sugar goes up, and these are inflammatory. That's why we have our full-time health coach, Olivia, to help us get moving. And she'll have some handouts about that related to what you can do to improve your exercise. With prevention, yes,
That
Rebecca.
screen right before there, is there, can we have a copy of that? I want
Oh,
that screen.
sure.
I want
Sure,
just
these are,
somewhere.
yeah, I meant to go into this in further, but there are all these risk factors that can be controlled. There are two of them that can't. One is your age and one is your genetics. And one thing we do in our practice here is do this saliva test where we collect your DNA and tell you, well, you're at high risk for a heart attack, high blood pressure, atrial fibrillation, high cholesterol. Well, doc, I have all those things. Why are you telling me this? He says, well, part of it is just to complete the picture. But some people haven't had that stuff. And so we can individualize your care and also kind of set your mind at ease that, okay, you have all those risk factors, you've had all those diseases. Well, it isn't a character weakness or something you did wrong, it's in your genes. Now let's go over to the controllable risk factors and really get serious about those if your genetics are positive for all these problems that you have. Now we've seen other people who have very low risk factors from their genetics, and yet they've had a heart attack, or we do their carotid test and it shows a lot of blockage in there, and then we'll start talking and say, well, you don't have a risk factor from your genes for high cholesterol, for high blood pressure, for a heart attack, for coronary disease, for peripheral artery disease. How come you got all this carotid plaque in here? And you know, I recently was talking to one 90-year-old gentleman, and he was saying, well, could it have been all those cigarettes I smoked when I was younger? Said, well, how many did you smoke? I said, well, I smoked 2 packs a day for about 40 years. And I said, well, and you don't have emphysema? He said, no. Well, you've got some blockages in your neck, and that probably explains it, because you can't blame your parents. They left you with some really good genes. So this is the value of kind of putting the picture together, and the value of getting as much information bearing on this topic as possible. Now, Olivia will take it from here. You can see from this that of all of the prevention of heart disease that we can do, some of it involves getting to the doctor, some of it involves genetics, some environmental pollution, but 50% of heart disease can be accounted for by our lifestyle. And that's what we're all about. Yes, Marlene?
I was wondering, is restless leg syndrome related to not getting enough oxygen in your blood, or is it related some way to this?
It does correlate as a minor risk factor for heart disease. So we consider it a red flag, and we want to go looking for inflammation in your system by doing our testing if you have restless leg syndrome. So it is migraine headaches too. And I have migraine headaches, and I haven't had one for about a year, knock on wood. But getting my weight down, getting my blood sugar down, getting all of these lifestyle things under control, I haven't had a headache for about a year now. So considering the stresses we all face in our daily life. I think that's pretty amazing. Any other questions for me? We'll take questions at any time, but Olivia wants to talk about this huge part of the puzzle right here, the health behaviors. See, this is what I do prescribing Lipitor or cholesterol lowering or blood pressure medicine right here. But Olivia's really has the greater impact, and I try to help her with that by coming up with non-pharmacologic ways to treat your blood pressure and your cholesterol and your blood sugar. So, any other questions? I'll turn it back over to Olivia.
Okay, we'll go through this fast so you can eat all the goodies that we have for you. All right,
There was healthy goodies.
healthy goodies, yeah. Okay, so this also correlates to the risk factors in heart and cardiovascular disease. So, and these are all percentages within people that were tested that have heart disease. So here we have all the heart factors, or the risks down here. So diabetes, high cholesterol, cigarette smoking, high blood pressure, obesity, and then inactivity, of course, is the biggest factor that people have had. Okay? So then why is physical activity and exercise so important? We all hear exercise and we're like, exercise. But it is increasingly important, especially to your heart, and here's why. So it decreases your resting heart rate. So that left ventricle on that left side that pumps the blood to your heart, it gets stronger. It's not slow, or it's not slow, but the muscle itself gets stronger as you exercise, so it doesn't have to work so hard to get the blood to the rest of the body, which also decreases that resting blood pressure as well, because your heart is able to become more flexible. Sometimes when we're inactive, we're not getting our heart rate up, we're not using it, that muscle gets stiff. And so that filling period, where that diastolic, that last number, that filling period is also very important. So the blood's able to fill and relax to get that blood into the heart, and then it gets stronger to decrease that blood pressure that's being pushed, so it doesn't have to put so much pressure on that heart to get it to the body. So all that creates that decrease in the workload in the heart. And then also your body is able to utilize and intake in more oxygen. So as we exercise, your muscles are able to be more efficient, and so they're able to utilize the oxygen that's brought to them, which also helps decrease fatigue and also create more energy. That's why when a lot of people say they're very fatigued and they don't exercise, that's like the number one factor we usually say to keep or to start doing. And then also decreases body weight and fat storage, decreases blood cholesterol and triglycerides, because exercise also activates enzymes that help break down triglycerides and cholesterol that help the body utilize them, and then also decrease insulin resistance, and that's a really big one as well, as we've seen here in the practice. And then exercise used as a prescription. So they use it in cardiac rehab. So cardiac patients, they go exercise after they have their heart surgery. And it's reported to increase their self-confidence, their sense of well-being. They have less depression and anxiety and stress and social isolation. And this is a big one, social isolation. When I used to work at the YMCA and I'd work on the floor, it was like everyone just wanted to come talk to you because it's their way of getting out. And it's also, it's great for people because half the time they're there for 2 hours, but they're not really talking, or they're talking half the time and then working out the other half. So you're getting 2 for 1. And then this is a big one. So 82% reduction in risk of coronary artery disease, and that's much more than taking in statins, taking in pills. Rehabilitation in heart attack patients results in a 25% lower death rate. And also exercise rehabilitation is safe and with serious events and cardiac events are reduced in people with regular physical activity and exercise. So how much is that, or exercise is enough? Aerobic activity, getting your heart rate up for between 30 and 60 minutes. Obviously, if you're not exercising regularly, we don't want you to start out and go doing 30 minutes of brisk walking. We want you to build up a little bit to get up to that 30 minutes, and that takes time. And then also resistance training, so about 2 to 3 times per week, 8 to 10 different exercises, 1 to 3 sets, 10 to 15 repetitions, till you get that moderate fatigue. So not very heavy, not super heavy weightlifting like bodybuilders, but just enough till you get a little bit of fatigue. And I thought I was going to say something else, but I forgot. And then this was interesting. So healthy lifestyle, 1988 versus 2006. And so what they were looking at was adult ages 40 to 74, and then obesity. So these are just percentages. So 1988 to 2006. I couldn't find any other recent ones, so 2006 was the closest. Obesity, 28 to 36. Smokers decreased a little bit by 1%. Regular exercise decreased by about 10%. And healthy diet, this is the biggest one, 42 to 26. So, and then these are all the awesome factors to keep a healthy heart: fruits and vegetables, whole grains, low-fat milk, all the keys to the puzzle, physical activity right here, all that good stuff. And so here we have some different handouts for you guys that you guys have. So you have the new Nutrition Action in your hands, which has some really good stuff in it. See if I could find the top of it. So you have your Nutrition Action. And here you have, inside there's an article called The Exercising Truth. And Dr. Morris and I were looking at it. I'm looking right now. We're looking at it, and it's one of the best things that kind of goes over everything that we're talking about. So one in there, it talks about the truth and false of exercising, what works, what doesn't. And one, it talks about if you exercise, it's okay to sit the rest of the day. And it says false. That one's a really, really important one to look at. And I also have another article, it's over there. But it's a little handout too, and it just goes over all the different factors into what sitting can damage our health. So it has from different organ damage, muscular degeneration, leg disorders, neck strain, bad back, everything like that. And one thing it talks about in here is just getting up and walking every few minutes. And just a little bit from walking to a chair to a cooler is better than just sitting there at all.
You mean like to get a beer?
Yeah, get a beer. And then also another one, wearing a fitness tracker to help you lose weight. That one's true. And then it talks about Fitbit and having something to track your movement. And we actually have Fitbits if you ever want to try one and take one and see how many steps you walk during the day. We can actually track all that. And then when it has the respirate in there too, which we have as well, which is checked out right now, but it has some different information on that too. And approves it in nutrition action. So
It's
any,
the only FDA-approved device to lower blood pressure is the respirate device, which it's not that cheap. It costs $300. We have one of them here we've been loaning out to people to try if they don't want to take any medication for their blood pressure. But if you take $1 worth of pill a day for blood pressure, then in a year you've paid for this device. And it involves a musical tone that you listen to through earbuds, and then there's a band around your chest or abdomen that measures your breathing rate, and the musical tone slowly drops in its rate, and you breathe then more slowly, and that lowers your pressure. It sounds too simple to be true, but it actually works, and it can also help you sleep. So that's an option, a non-pharmacologic way to get your blood pressure down.
and then also the other handout talks about foods and then inflammation and heart disease. There's a couple different stuff. And the inflammation one mostly talks about nutrition and focusing on more of a Mediterranean type diet. With nuts, good oils and fish and vegetables and everything like that. So, any questions? That's it. Unless Dr. Morris has anything else he wants to add.
No, I wanted to thank you all for coming, and we can just